Hi, welcome to the International Interprofessional Mentorship Program. I am Kate Barlow, the founder of the program and host for today's meeting. It's December 2nd, 2021, and today Dr. Meral Huri is here to present on NDT. Please mute yourselves during the presentation and unmute yourself whenever you'd like to ask a question. You can also type your questions into the chat box and I will ask the questions for you. In order to receive a certificate of attendance, please enter your full name and email into the chat box now, and you will need to remain on the webinar until the presenter is finished. Thank you all for coming today, and let's get started. Thank you, Dr. Huri, for coming. We really appreciate it.
It's my pleasure to meet you and also to be here with colleagues. It's very great feeling that we're connecting online, and we are having some things about occupational therapy. That's very important. Thank you for all your help and for invitation. Thank you very much. Hi everybody, I am Meral Huri. I'm from Turkey. Now I'm in Belgium. I will tell you about it in 5 minutes, not to take too much time, but I am a physical therapist. But during my, or the time that I get graduated, occupational therapy was not a school in our country. It was just a master program under the physical therapy. But I started my PhD and my master on occupational therapy, and about 10 years ago, we established the School of Occupational Therapy in Turkey by the help of colleagues from Europe, from ENOT and WFOT. They helped us too much, and actually, I am a PT, but I'm not feeling like PT. I'm not acting like PT. Yes, it's a different profession, but I had been always in occupational therapy and looking like occupational therapy. And here is my little CV. I'm working mostly on pediatrics and patients with cancer. Actually, I'm a Bobath therapist and SI therapist with sensory integration, iris sensory integration therapist. During my all my professional life, I've been to USA in Texas Women University with Patricia Boyer, and I was in Austria, and now I'm in Belgium. I'm here following a project which combines OT and PT and in mental health. Actually, occupational therapy in Turkey is not yet paid by the government, so I'm working on but PT is paid by the insurances. So I'm working here to establish or to make a project which is the complementary professionals. They come together, and how can we have paid by the insurances? So it's our pleasure to do such an activity here. This is my university in Turkey. I'm in Hacettepe University, which is the best. I'm just telling this, but this is the truth. Which is the best health sciences and medical school is in it. So you see our buildings. We have the hospital, we have the oncology hospital, pediatric hospital. Also in our department, occupational therapy department, we have the fieldwork areas for our students. Which is very important. I think that we can see patients, lots of patients in our building. So if you want to come to our university for visiting or for exchange programs, we are very welcome to you. And also this year we had an email from an occupational therapist, graduate from South Africa, and she was working in Cyprus. So she will come and start a master program in our program. So as I want to add that we have the master and doctorate degrees in our school. As I say, I'm much more working on pediatrics, on autism and cerebral palsy. I have 2 books on occupational therapy. That's why I'm telling this, because after the presentation, if Kate says, okay, I want to send these books to occupational therapists in Africa, so maybe we can design something with Kate, or we can ask a question, and then the one who answers the first have the book. I don't know. We will decide during the presentation. And also we have a occupational therapy journal. Actually, it's indexed in some areas like Google Scholar and in EBSCO hosts. So we're trying to make it much more known. So we're waiting for your articles from Africa or from America. That we will be very nice, and I can share the addresses also. It's the Turkish Journal of Occupational Therapy. So this was my university in Turkey, but now I'm in KU Leuven University, which is in Belgium, and which is the 4th great and biggest university of Europe, and was established 700 years ago. That our university is 50 years old, and we say, oh, our university is very old, but this university is, as you see in the picture, is 700 years old university, and the Department of Rehabilitation Science and Kinesiotherapy or movement therapy. It includes occupational therapy and master programs and PhD programs for occupational therapy. So it's one of the best of Europe. So I will also want to introduce this university, because they are having me guest and they're my host. So it's also quite nice to be here. Okay, this was all about me and where I am. So it was the starting. Yes, what we have today. You know, Bobath, I'm working with children, and in Turkey, as occupational therapy is quite new, we're trying to do lots of things, because the people who are interested in occupational therapy are not so much. So, for example, I'm working in autism, but I'm also seeing patients with neurodevelopmental delays or neuropathologies. So it's my honor to present this PowerPoint to you, that I saw another PowerPoint or presentation that was done by an NDT lecturer. That was a very nice presentation, which gives the idea of and the basic theories of Bobath. So I just wanted to add some things to that, and also I wanted to put some videos and photographs, and just to have a look what we can do, because seeing sometimes is an opportunity to learn, and to know what somebody is doing out of my country is important, because I always did this. I followed some colleagues from foreign countries and look for what they're doing and try to do them in my country. So I think it will help you. You know, the Bobaths, they're very nice. They're Dr. Karel Bobath and Bertha Bobath. You know, Bertha Bobath was a physical therapist, but at that time there was not too many physical therapists or physiotherapists. We say that she's a therapist, and she was actually married with Dr. Karel, and actually he was the one who is giving the ideas to Bertha Bobath, because Bertha was working with the patients, and she was trying to find a way to move them, a way to make their movement easy. and she was working with the CVO patients, and also she was working with, as now we're using NDT, or I'm working on pediatrics, but Bobath was started with elder people or adults. So it's important to know that the things that we're going to talk today are the same with the adults, but also with the pediatrics, because the basics are the same, the theories are the same, but just the activities we use are different, because children loves to play and we want to involve them during playing, and for the adults we're always playing, but we're also putting some daily living activities or more structured activities than the children. And also, you know, NDT is a living concept, because during newly developments on neuroscience, we see that neuroscience that is now being found, the theories are supporting NDT and Dr. Bobath's theories. So also the individual is changing, the environment can change. So it's a living concept that we say. And but as I love this Berta's sentence, we give love, not exercises. So if we think globally, doing exercise is something very limited that we, as occupational therapists, we don't support too much. We support being holistic, we support doing activities, daily living activities, and to increase the participation to daily living activities. So the activities we do with our patients or the clients are not exercises, they're type of living and trying to change their way of standing, their use of hand use, their visual skills. So it's not just exercises. So as we know, or as you know, individuals with disturbances of postural control, movement and function due to central nervous system use this theory. So we're working with the ones with central nervous system problems. So it's okay with cerebral palsy, with children, but with adults with cerebrovascular accidents are our clients in this approach. As the most important thing that I think is it is a hands-on approach, that we use our hands, we put some pressures, we give some support, sometimes we're using some facilitations, so that we are using hands-on. But it's the most important thing is it's practiced by OTs, PTs, and SLPs, which is very important now, because when you learn about Bobath or NDT therapies, you have to work with the therapists. When I say therapist, I mean the three therapists actually, because if we're not very close and we cannot put some goals together, we cannot increase the participation of our clients if our client is a baby, as you see, because all the aspects are the same. In the NDT or Bobath concept, we say that an OT or an PT or SLP can work with a child or with an adult with cerebral central nervous system problems. So, for example, PT can work mostly on walking or standing, but at that time, OT can work with all these, and additionally to hand motor skills, fine motor skills, and visual perception or sensory issues. I'm not telling here the sensory integration, but sensory issues which are very important in the central nervous system and this concept. We know that it's holistic and it's this interdisciplinary clinic practice, and all the research that emphasize individualized therapeutic handling based on movement analyzed for rehabilitation of individuals with neurologic pathophysiology. So this is the main definition of this concept. And the thing that which is very important is the ICF model that we're using, or nowadays it's popular and it's something that changed the site to rehabilitation, is very important. And also during this time, when we are doing NDT or Bobath Concept, we have to be problem solvers, and problem solving approach is used to assess the activity, the participation, and to identify or to put goals for the clients or for the caregivers. Because when you think of children, a child of 9 months cannot come to you. He comes with the parents. Parents bring their child to you. So it's important to work with caregivers. It's the most important thing of pediatrics, and maybe in the early intervention, the caregivers, mothers and daddies are our biggest supporters, and we have to teach them, because when we have a therapy twice a week or once a week, we can see a patient or a client, a pediatric or an adult, maybe in half an hour or 25 minutes. But if we teach caregivers and tell them how they can manage the problems, they can increase, by this way, we can increase the time to 24 hours of therapy. For example, for positioning, for doing an activity, during eating, everything is something must be much more, not therapeutic, but must not to make the client bad, or positioning in a bad situation, or sitting in a bad way is really a problem for our clients. Is it going nice? Do you understand? I don't know, because I'm not seeing you. It's just like that I'm talking to myself, but please disturb me if you have any questions.
Everything is going great, and I will interrupt you if there's any questions that come through the chat box.
Okay, thank you very much. And okay, we want to work with NDT. What we have to have, do you think of this? Okay, we have to be holistic, interdisciplinary, and we have to be very problem solvers, as all OTs are. But for NDT, we have to develop our analytic skills, because it's important to see the relationships between participation, activity, posture, movement, multi or single body system integrities, and other contexts that we're doing all this in. So it's something very mixed, but if we can look in basics and simple, we can do all that. So try to increase your analytic skills, try to find the problem and try to observe. And for all pediatrics or for all occupational therapists, observation is very important. But in NDT, you have to observe the client in a safe and very trustworthy, because that will tell you what is the problem. And when we observe our client, we can find the main problem of the child. And if we can find the main problem, we can design a therapy easily. But if we cannot find the main problem, otherwise the therapy will not work, or will work, but in too many times or too long time. So if we can find the problem, the therapy will be on that, and we can solve the participation problem very easily. And clinical reasoning, that which is very important, its ability to determine a range of prognosis, taking all factors into account and correlating to outcomes. That what we are waiting for the therapy. This is very important, that we have to, as I'm working with pediatrics, all the moms are asking me, oh, my child is going to walk, or when is he going to eat independently? Is he going to write? Would he be able to grasp a pencil? So they're always wanting something. They're actually in Turkey, they're comparing their child with the other ones. So I said that this is not a problem, that every child has his own goals and his own development, so we can do it together. So in this way, we have to find a good clinical reasoning skills. And goal setting, which is very important. We must put some goals with measurable outcomes, and in which time, and what we want to do. For example, in 3 weeks, in 4 months, our child will sit 5 minutes independently. For example, we have to set some goals. And during NDT, we're setting goals in that session. Just when you observe the kid, or when observe the adult coming in the therapy room, you're trying to find, oh yes, what can we do today? What he wants, what's the motivation of the client, or what was our previous assessment and what we did in our previous session. We have to find the main problem and go for that. And if actually in the practice, if you're not changing something in the therapy room at that day, it's not a nice therapy. So try to find little small aims and goals and try to make them, because we're working on neuroplasticity. So we're not going to make the child or the adult run in a few minutes. We have to put little goals, and each session must have its goal. For example, if the child doesn't have symmetry, we have to work on symmetry. Or if the alignment of the child or the adult is not nice, is not good, so we cannot work on symmetry. We cannot work on postural control. We cannot work on hand-eye coordination. So it's important to see the child, to be calm and work together. And at the end, I have some pictures and videos that all of them are my patients. So you can find lots of things in internet via YouTube, and there are lots of videos of children. But I wanted to put what we're really doing in our country, because as you know, money is very important. Equipments are very important during this area or this time. If you don't have equipment, you have to find something. You have to do something in your goal, about your goal. Maybe you don't have a treadmill, but you can make the child or the adult stand. But how can you stand? You have to use your imagination, actually. And the ability to plan general intervention strategies that will address the body system impairments, activity limitations, and participation restrictions. As you know, we said that we're working on ICF. So body system impairments are very important. We have to know what we are working or what is under our hand, what is the capacity of the client. But the most important thing for OTs is, I think, activity limitations and the participation restrictions, because in NDT Bobath concept, as Bert Bobath tells, we make the activity possible. We're trying to make it possible because we know cerebral palsy or it's not developing. Everything is the same in the cortex, in the brain. It doesn't goes better. We have to participate the client. We have to do some environmental designs, because as we do this, the participation will increase. And also we have to do a realistic episode to care them, and to meet our outcomes. And home programs are very important, and effective postural movements in daily routines are our aim. You know, if we don't put our therapy in the daily living routines, that will stay in the therapy room. So we don't want it. And as an occupational therapist, we have to know the assistive technology that we're using with pediatrics or with adults. How can we make them stand properly? Can we use some orthesis, or how can we make a child to hold a pen or a spoon much easier without without increasing his spasticity, or without asymmetry, or with proper weight bearing? So it's important to use assistive technology, and it's, you know, it's a teamwork, and the value, the opinions and priorities are important. So, and also to plan an examination, an evaluation and discharge programs are important for us. Okay, this was the beginning, and that we must tell you during the presentations. Otherwise, it will be limited. Why we're not? You can ask why we didn't talk on this. But for therapies in NDT Bobath, you have to know the human movement system and motor control. If you don't know how movements develop, you cannot understand NDT Bobath. Actually, yes, we're therapists, and we're working on participation much more. We want our clients to participate in daily life and use their hands and use their visions and be productive in their life. But if we think in this way in NDT areas, we can have some problems, because doing is everything. Okay, I'm with that. But if a child, think of a child that he has a spasticity, and he has an arm like this, and he has to take something. Here, I have this on the table. He have to take this. But if he's taking this object with body flexion, or if he cannot open his shoulder, his elbow, he cannot control his wrist, that will not good for his future. Because if he stays like this, and if he take the object with his body flexion, that he will lose his range of motion, and later he will not participate the activities that needs range of motion in the shoulder or in the elbow or in the wrist. So we have to be very careful to use our movement systems, and we have to think. In my students, in Turkey, when I ask them about motor skills, they're saying, oh, leave them to PTs. They can do motor skill educations. But it's not true, because this is a whole therapy. It's a whole vision that we have to increase the movement skills, the range of motion. We have to decrease spasticity. We have to know how we can improve the movement or the motor control of the child or the adult. So we have to know how normal or typical movement develops. It's very important. And we have to know about the motor control and motor control theories. That is another PowerPoint. There's another presentation. Maybe we can do it later. Or we have to know the motor learning, because we want repetition. We want plasticity in the cortex. Without repetition, we cannot do it. We cannot learn. But for motor learning, if you do the activity in bad way, without symmetry, without giving weight, without motor control, without gross control of abdomen, you cannot send typical or normal senses to your cortex. So positioning and positioning during sitting or standing, or positioning during activity participation is very important. And also for the movement system, additional, we love to know, or we have to introduce you or ourselves to typical and atypical development. Yes, every child is going up, they're getting bigger, but it's important to see their horizontal development. What the client do, and what this skill will be based for another skill. So we have to know this. So for example, when I look, or when a therapist see a child, oh, she have to understand, okay, the child is 5 years old, but the skills are 2 months. So we have to know typical development to identify atypical issues. In the adults, this is a little bit easier, because the children, the growing brain does not know, they don't have any normal feelings of movement, feelings of body awareness. But when we're working with adults, this is that they have previously know about the activities. Okay, they would have neglects, they would forget to use their involved side, but they have that idea that we have to make them remember, make them teach them to understand, or to do this what before before the accident or before the diagnosis of CVI. So children are a little bit worse, because they don't know anything. They have to know them, and they have to expertise typical development. But if they expertise always atypical development, atypical activities, you cannot wait typical behaviors, you cannot wait typical participation to activities. Actually, it's, I don't know, must it be typical? No, it mustn't be typical for a child with cerebral palsy, but the thing that it must be as nice as possible. And also postural control and movement, as we talk. There are some points that is important for NDT, that it's a living concept, and all the current scientific findings, and especially for principles of neuroplasticity, motor control, motor development, motor learning, are connected to Bobath's findings. So it's a living concept, and it will change. It is changing every day. What is new? Okay, what can we add about for our therapies. We're thinking on this way, so it works. And also, therapy always works. This is important that we have to work whole day maybe, but in the participation area, and treat the individual as a whole. We cannot say that, oh, the hand is okay, or the spasticity is okay, but the other side is not good. So we have to take the child or the individual as a whole. And we have to increase the individual's activity and participation. And during our view to clients, it's important that the client's strength, we're not concentrated on what the client cannot do. We're concentrating on what the client do and how he do. So we can change how he's doing. We can make it better with his strength. And always we're looking the past, present, and the future. What we have, what we had, what we are now, and what are our aim, and what are we going to do. As we say, teamwork and typical development is very important. And also hands-on and hands-off interventions approach, for evaluation. For example, you're seeing a patient, and for the evaluation, you're not touching the patient too much. You cannot, because if you touch, you can facilitate something. So evaluation must be hands-off. You have to, for example, for a child, you can evaluate the child in 3 positions: when he's lying on the floor, when he's sitting, and also when he's standing. So the main problem must be the problem in each evaluation: when he's sitting, when he's standing, and when he's lying on the floor. So if the problem is weight bearing problem, or it's the problem is symmetry problem, if the problem is postural control problem, you can say that postural control problem must be seen when the child is sitting, must be seen when child is standing, must be seen when child is lying on the floor. So the problem must be in each level. So it's important. But for the intervention or during the therapies, we have to use our hands. We have to do some facilitations. For example, you're working with a kid with increased spasticity in his hand. He has the child has a pattern, and if you want to open his hand, if you start from hand and fingers, you will never open it. You have to start from the shoulder, or from the basic, from the area that is close to the body. So you have to relax the shoulder, and then elbow, and then the hand, and that we see ulnar deviation too much, and the hand. Also, by this way, you can start working with the hand. Otherwise, you cannot work with the hand. So it's important to look at what you are doing, the area that we are working, but it's much more important to look to other areas of the body. For hand, you have to look the elbow, and shoulder, and the core. If the core of the child is not good enough, he cannot do any fine motor skills. So you have to know, if the child cannot bear weight on his shoulder, on his wrist and elbow, that it won't he won't use the hand properly. So it's, as you know, I'm not talking too much on this, activity, participation, body functions, and environmental factors, and personal factors as context of. So it's important that we can find them everywhere, but participation is involvement in life situations. So for adults or for child, it's not important, but life situations, we have to participate the individual to life situations. So it's very important. So during this we're not using ICF. We're using, for example, ICF child for the children. So we can put some other areas that about participation, like walking to classroom or playing during races, physical education, or activities like slopes and crawling and climbing. Or for a patient with stroke, we can use different activities which affected from the personal and environmental factors that you have to, for example, if you want to work with this kind of client, you have to prepare your own ICFs that will help you to understand the goals and where to start. It will be easier. And also, there is the ICF framework and the F-words that was done by Ken Child that we had these in Turkish also. We did the translations maybe, and I always put this posters to my room and to my therapy room and give them to parents. And also we always fill forms like this. You see here, it's one child's form. It's ICF, but it is like ICF, but in structure and functions means fitness. We put fitness for that, for children. Activity for function, participation, friends, and environment factors, family and personal factors like fun. So it's much more easier to understand and to set a goal for occupational therapy in Bobath and NDT approach. We have lots of from them. You can find them in Ken Child website, and also ask them to translate it to your language, and you can put it everywhere. That makes to understand ICF deeper for students and also for families, for the clients also. Yes, it's the actually clinical practice area that we talk too much on Bobath, the main ideas, the main structure. But yes, if we want to work with a child or work with an adult with central system problem, that we have to find the activity, task, and postural selections, and we have to individualize the treatment. So, for example, for this, we have to first diagnose or work on the movement and observe the movement, what the client do, what cannot do, what can do. So afterwards, seeing what he's doing, we have to hypothesize why he's not doing. He cannot put his hand up. Why? Because he doesn't have a range of motion, because the muscle is weak, because his core is not well enough, his hand-eye coordination is not nice. But during this time, we have to do it like this. He is doing his raising his hand up, but this way. So we have to work on which way he do it, which way he cannot do it. So it's visual, spatial, kinesthetic perception is the most important thing that OTs work also. And we have to understand the sensory information too much, because if the child or the adult cannot sit properly or cannot take sensory information well, then the motor answer will not, or the motor response will not be good. So how good the sensory information is, the reply of movement will be that much better. So it's important. So this is something that I like. So when you see it, it's like doing the assessment or like planning the therapy in NDT for even for adults or for children. It's important to start assessment during when the child or when the adult comes in the room. For example, for a child, is he walking? Is he does he have something in his mouth? Does he use some glasses? Does he what's the emotional skills with the mom or the dad, or how is the parents there? Because we will work with parents. How is the parents? How is their connection? What is his basic skills? So during when he's coming to the room, we have to address the client's gross motor function. Which level is that? We have to understand manual skills. The manual skills, we can do max test for cerebral palsy, for example, or we can take some ideas how he's eating. Is he eating, or does he have drawlings, or he's always putting something in his mouth, or he has a modulation problem. So it's important that you start assessing the child from the door of the therapy room. Actually, it's the same for the adults, because you have to see how the adult is walking and coming to you, or is he using a Canadian or something to walk? Does he use a mold? How is his hand position? How does he use eyeglasses? Or does he have a symmetric body? Does he can he weight bear on the foods, or does he have a position like this? He cannot make extension. So it starts from here. So it's important to control the sensory motor performance of the client, and with also postural control. Postural control is the main idea of NDT, because we're going this way, we're going flexion, we have to be active, we have to use our backside, we have to use our abdominals, we must be always active. When we have to do them, to make them active, we have to weight bear from the hips, from the foot, from the knees, and also we have to weight bear from the hands. So postural control is very important, that how we manage with the gravity. If we cannot manage with the gravity, that means our center of weight goes out from our base of support. That means that we cannot extend ourselves. If try to think of a child, try to walk like this, like kyphotic like this. But if we can make him like this, straight, if we can give support to win the race to gravity, that will be very easy. So, and then we have to find an activity, that selective activity. We have to think of that. For example, for a child, you can say, okay, how is he going to play with a car? Can he hold the car? Or can he hold the car when he is lying? Can he hold the car when he's sitting? How he holds the car when he is standing? Or how independent he is during this time? So try to think of these and then try to find the problem. And what kind of problems? I've always talked about postural control problem, symmetry problem, or co-contraction problem. These are the main problems that we can see in the clients with central nervous system problems. So first, try to observe all of these, and then try to think, how can I make the client move properly? If I support from the knees. Does he can stand much more like this? Or, oh, it's not enough. Just from knees, supporting from knees is not enough because the hips are very relaxed. So maybe I can put my hands to the hips and control the hips to weight bear, because for adaptation or for a nice postural tone, the child or the adult or the individual have to weight bear. For example, when you can see the child or the adult when he is sitting like this, but when you make him up and when he try to weight bear, you see that the spasticity will go down, and then the movement can be much more easier. And after these, you have to make hypothesis. Okay, if I support the knees, or if I support the hips, maybe he can stand much more and he can use his hands much more better. So we'll try that with facilitations, and then we can see that doing is everything. So if he can do the activity, then the nerves starts to work. So it's important to do something for plasticity. And if we can increase the participation, plasticity will be much more better. So it's important to know for the pediatrics what the child is doing. For example, let's ask this question. The one who gives the first right answer will take one of the books. As you see, there is a child here, and for the second picture, what do you think? What old is this child? You see he's standing on his hands, he's putting his head right, and he has a nice lordosis here. How old is this little boy, for example? What do you think? Is there any answers? Okay, I'll give the answer at the end. Maybe someone writes something before 6 months is obvious, but 1, 2, 3, or 5 months. This is important. Yes, I think you will have the.
So Patience said 3 months in the chat, and Timbas said 4 months. Is that Emmanuel? Timbas? So Patience said 3 and Timbas said 4.
Yeah, this is 4 months. It's actually 4 months. Yes. You know, this lordosis is very important for the baby. In 4 months, he's doing this. And in the 5th month, they start to go back and take the feet up to the mouth to prolongate the extensors, and by this way to increase the abdominal strength, because the child will need this abdominal muscles to sit at 6 months. So this is 4 months. At 5 months, he's going to take the legs up to his mouth, and at the flexion and extension in the hips, the control, when the control is okay, then they will go sitting. So it's very important. And for the 4 months, and the child is doing chin tuck, you see here, if the child is doing chin tuck, that means the body control is okay. So these are the things that I love to present always. Okay, we're going to send one book to the one who answered the right. Okay, thank you. And postural control is what we're always talking on. And postural control is we need the writing reactions, we need the protective reactions, and we need the equilibrium reactions. As you know, for the adults and for the children, it's important to increase the reactions. And for the children, it's important to inhibit the primitive reactions, and all these reactions will turn to Writing's protective and equilibrium reactions. And if we can work on these, the body control against gravity will increase. By these reactions, we can keep our weight, center of weight, in the base of support. That means we can do it. That means, for example, think of a boy or a man. He's standing very widely. His legs are very wide, and he can stand just like this with wide range of food, because base of support is very big. So he can manage at this way to stay center of weight in this area. So we have to support him and work to decrease the support on the base of support and make him much more doing protective reactions and equilibrium reactions much more better. So to increase all these reactions will help to increase the voluntary movements. For example, for an adult, he wants to walk. If you cannot increase the equilibrium reactions or protection reactions, he cannot bear weight to the foods he cannot use. Or if you cannot do the protective reactions during sitting and equilibrium reactions, you cannot bear weight to the hands, and otherwise he will neglect the hands. So it's very important. So we have to find the normal tonus always. For normal tonus, giving weight is the answer. For example, if you want to, if the child is spastic, has too much hyperspasticity, or if a child is very low, like jelly, then you have to control the normal tonus. You have to do the normal tonus. So for normal tonus, you have to weight bear. If you weight bear, if the child or the adult weight bears, then the tonus can go normally, because too high is problem, too low is problem. And it's important to work with normal movement patterns, because every pattern, every movement sends senses to cortex. If you send normal senses or normal activity senses or normal weight bearing senses, the cortex will increase. So you have to do it with activities. It's not important to do an activity without wanting or without desire. It's important for motor learning. If the child goes happy, if the child wants to play, if an adult, when he's working or having therapy, he's doing something interesting for him, it's very nice. That will affect the plasticity, and repetitions are very important. So we have to weight bear. We have to do all these in alignment. For example, if I'm sitting like this, you see I'm not aligned. I'm like this. You have to be aligned. Yes, there are some new activities on therapies. For example, in Turkey, we have newly some therapists is working on anat banial. I don't know, do you hear it about, or do you have that? It's something like it believes like NDT, but NDT is much more strict than the other therapy. For example, we don't let, as NDTs, we don't let the child to sit in a bad way or to stand in a bad way. But the other therapy says, okay, he can sit however he wants. The important thing is the sensory issues that he takes. So I had a patient. We started with him. He was cerebral palsy. He was right hemiplegic, and we walked with him at 1.5 years. He was 1.5. We walked with him, but we were using some ortheses. He was walking a little bit straight, but he was walking. And then his mother changed her idea, and he had some different activities, therapy activities. Now he's not taking NDT. He's doing some things other, which helps the child, or which child can move too much in sensory areas, but in not very strict rules. So it's that we see that the child's sensory system is going very well, but the motor system is not going well. Now he's not standing, he's not sitting, he's not, but he's much more happy. I don't know, he has some molds, he's using some molds to stand up, but it's important to find a way for the therapy which is best for the client, which is good for the family. So the family is happy with this way, the child is happy with this way, so it's their choice. So it's important to focus on the activity also for the movement and sensory inputs. Here you see these are all my patients that we're working on. You see this is a baby that she doesn't have the lordos. You see the hips are very open, so what we have to do, we have to make her a little bit upright. We have to make his lordos, so his back ankles, back muscles to be much more strict, and he can by this way do his head like this, and then the chin tuck will come. So we have to work on this. And also if we increase this ring position, you see, if we can do it a little bit straight, that he can work much more on the gluteus muscles and at the back. Here you see another child that I've sit here, and this is a nice sitting position for children, because you can support the back, you can support the knees, you can put the hands, the child can use his hands, and also his vision. So we love to sit like this with the children. Also, we sometimes we sometimes prefer to sit in one leg. The child opens his leg and sits on my hug, so he can have some stimulation from outside. And here you see we're giving some pressure on the shoulders and back, and that the child's hands are much more capable by this way, because as we say, we're giving weight bearing, and the posture and the tonus can go good. So we're giving backwards pressure, and the hands go like this, and she can play much more like this way. Are we okay? Is it too long, or shall I be? I don't know the time. Sorry. Let me. Okay, I think I'll finish in 5 minutes. 5 minutes. And you see there are some that we're using for standing. We're using balls to stand, because with this with hands he can have sensory issues also, and he can feel the gravity. As you see, these are 2 examples from our clinic. And you see the handling is very important. Here you see we're just trying to do the child in aligned position, because handling and giving the mom this education is important, because you have to teach the mom how to carry the child. So it's important to use this carrying, this side carrying or front carrying for alignments, for increasing the alignment at every time. And here you see a child with cerebral palsy. She has pain in the hips. As you see, this standing in the middle is not very nice. So we firstly started on lying position. We gave a little bit left and right weight bearing, and we designed the tonus, and then we stand up, and we put something to hold the knee, and that will increase. You see the abdomen and shoulders and the looking and the face. The middle one is not a qualified, it's not a nice standing, but the third one was nice. So during one session, you have to do these for the therapy. And sitting is really very important for us. You know, we can use this kind of car seats or some seats for sitting. So it's important that how the child is sitting, and sitting in core is important for eating. So it's important to use materials that help us. And also if the child is not standing anymore, we have to use this walking, we're saying walking help. So these are very important for us. Also, during the COVID, we couldn't see our patients, but with online rehabilitation, we did some things. These are some examples of that. For example, I'm online, but the therapy is done by the parent. You see here, for example, yes, she holds and stands up. She holds and stands up. Or here we can. Do you see it? What happened? And stop it. And here is the same.
Elif otur bir otur. Otur hadi. Otur. Hadi gel.
Mom says sit. Do you see the video? I cannot see it.
Aferin.
Okay. I don't know why. You see here he's in a standing table. The child is in standing table. We put a ball in the front of the child, as you see, because we want to help him to win the race with gravity. With the ball, he can go up this way. And in this, the daddy is giving pressure or weight bearing on the shoulders, and she can use, you see, oops, the feet go up with the weight bearing. So we work on this. All these were online, actually. So I wanted to show you. Yes, this was all. We have lots of things to do, but we don't have time. And I hope you understand me, because doing all the sessions in English, you cannot give the impression what you want to tell, or you can just tell the thing that it's much more important. So I hope you have a nice time, nice 1 hour. Thank you very much, dear Kate, for giving me this opportunity to meet occupational therapists from all over the world. You're doing a nice job, a very great job. Thank you very much.
Thank you so much, Dr. Huri. This was really great. Thank you.